This Week in Virology, the podcast about viruses, the kind that make you sick. This Week in Virology, episode number 341, recorded on June 11th, 2015. Hey everybody, I'm Vincent Racaniello, and you are listening to TWiV, the podcast all about viruses. Today I am coming to you from Glasgow, Scotland. I'm back, I think it was 3 years ago that I was here last, and I am at the brand new MRC, University of Glasgow Center for Virus Research. Our last two Glaswegian, right, TWiVs were from the old CVR. And we have for you today an episode all about Ebola virus. And we've collected a few individuals here in the UK who work on that. So let me introduce them now to you. Here on my left, for her second time back on TWiV, she is a clinical senior lecturer in the CVR, Dr. Emma Thompson. Welcome back.
Thank you.
You didn't say no because I guess the first experience was good?
It was painless.
Next to Dr. Thompson is a PhD student in the laboratory of Richard Elliott here at the CVR, Gillian Slack. Welcome.
Hello.
For your first time on TWiV. And then at the end of the table, he is a research fellow at the London School of Tropical Medicine and Hygiene, Adam Kucharski. Welcome to TWiV.
Thank you.
Did I pronounce your name
You
correctly?
did, yes.
Kucharski, all right. Now today is an unusual day in Glasgow because it is gorgeous, the weather's beautiful. Blue sky, right, it is unusual, right?
It's always like this here.
In fact, I got here on Monday and it's been like this all week. No clouds today, and the temperature is currently, this morning, 17 Celsius. You guys like Celsius, right?
We do.
You know, every time I do this in the US, they give me hell. They want it in Fahrenheit too, but we're not going to do Fahrenheit today. 62% humidity, sunny. You know, tomorrow's supposed to be the same, Saturday. Long range forecast, well, next Wednesday you're going to have rain apparently. But today it's gorgeous, so thank you for the weather. So we're going to talk about each of your experiences, and you each have a different experience with Ebola virus. I want to start though first by having you tell us just a little bit about your training. Emma, I know that you've done this before, but you're an infectious disease physician. You also do research here as well. Where did you train?
I trained in medicine in Glasgow, but then left and went to London and Oxford for 15 years. So I did my PhD down there and at Imperial College. I worked in Paul Kleinerman's lab in Oxford.
Right.
And then I came up here to start my first laboratory 3 years ago.
And you have both an MD and a PhD, is that correct?
That's correct, yeah.
Okay.
Yeah.
And you're still seeing patients, right?
I do, yeah.
As we'll hear today, hopefully, right? Gillian, you're a PhD student. I understand you're almost done.
Yes,
Right.
I submit this autumn.
Nice. Are you from Scotland?
I am, yeah, I'm from Glasgow. I did my undergraduate degree at Edinburgh, and then I went on and worked in Dundee. I did the clinical scientist training programme for 4 years, and then decided I'd like to do a bit more of the scientist aspect, and then started my PhD in Richard Elliott's lab almost 4 years ago.
And what are you going to do next?
That's a big question. I'd like to continue in infectious disease research and specialise in virology. Where that will be at this point in time, hopefully I'll know more soon.
So we mentioned on the last TWiV the unfortunate passing of your PI, Richard Elliott, and he worked right here at the CVR. I met Richard when he was a postdoc in the Palese lab. I was Peter Palese's first PhD student in the 80s, and Richard came on as a postdoc for a couple of years, and we got to know each other and did a lot of things together. We drank a lot of beer together. Richard liked beer.
He did, yeah. You had to work hard, but he would also be disappointed if you weren't the last one standing at the Christmas party.
So he was terrific. I remember as a young guy, he was running around. He worked really hard, which is not what everyone does, as you know, in science. Some people work harder than others, but he was terrific and really enthusiastic and kept in touch with him over the years. I'm really sorry to have him go. I'll miss him. He was a great guy. And you, Adam, you're in London, but where are you from? You must be from England, is that right?
I'm from the West Country originally. My background's in mathematics, so I did a PhD in applied maths at Cambridge, then did a postdoc with Stephen Riley in the MRC-Center for Outbreak Analysis at Imperial College, working mainly on flu transmission and immunity, and then moved to London School as part of an MRC fellowship, working with John Edmonds on emerging infections. So actually this was about 2 years ago, and subsequently been working on Ebola.
So when you were majoring in math, did you think you were interested in infectious disease at that point already?
We did some courses on kind of applications of maths and biology, and I think it's a nice combination of interesting, difficult, and hopefully useful. And I think biology is just full of these problems where we're getting more data, getting more information, and we want new ways of analysing it.
Has computational power changed the way you do epidemiology?
I think to some extent, and also just the theory. I mean, the data we have now with genetic sequences and real-time surveillance is just completely different, and we need new ways of understanding what's going on the ground.
Right. So you have done some epidemiological work on Ebola virus. Gillian, you went to Sierra Leone, and Emma, you cared for a patient with Ebola virus infection. So that's the Ebola virus experiences that we'll talk about today. I mean, we could start with you, Emma. You dealt with a Glasgow citizen who became infected. In which country?
So, yeah, my patient was the Glasgow patient
who's been in the news, right?
Yes, who had been working in Sierra Leone, looking after patients there who'd been part of this huge outbreak, and unfortunately came back with Ebola virus.
So she was from Glasgow. She worked in a hospital normally in Glasgow, right?
That's
we
correct,
know
near
that she's a
Glasgow,
nurse,
yes.
right? And had gone to do volunteer work there, is that right?
Yes, so she'd volunteered to go out to the Kerrytown facility in Sierra Leone voluntarily, and had spent a lot of time in direct patient contact, and unfortunately came back, developed a fever, and basically ended up being admitted under my care in the infectious diseases unit here in Glasgow.
So in the US, as individuals who work in West Africa return, they're monitored on a daily basis for fever. Is it the same here as well?
Yeah, it's exactly the same. The funny thing is that we'd had a kind of government exercise a month before where I was also on call, happily. And in fact, the scenario was almost exactly the same, and a patient coming through the airport and then organising a sort of controlled transfer. So we actually had an actor that turned up to the airport, and it was a very vigorous sort of actor, and I think there may have been other actors. There was a lot of sort of yelling and shouting going on when I got the phone call, which thankfully sort of started test. But then, you know, the scenario sort of came out. And actually, in the event, it was a very similar sort of scenario. And so we had the opportunity to run through the procedures that we would carry out for an Ebola virus case.
So how long after she returned did she develop the fever?
So she developed the fever on return, basically.
Same day?
Yeah,
Wow.
Same day as the return. And very sensibly phoned up.
So she checked her own temperature, right?
Yeah, so she was doing self-monitoring, as they all do on return. And those of us who've also been in contact with the patient for 3 weeks after that contact. So she noticed that she had a fever and reported it. And I was able to have a conversation with her and then organise the appropriate sort of ambulance crew to attend.
So she probably doesn't know. She probably was infected between 3 and 21 days previously, right?
I expect that's right.
And
yes.
she doesn't know any specific incident that would have led to that, right?
And I think there have been lots of cases like that where people have been unaware of what their exposure was. I guess, although it's not an airborne virus, it's actually relatively difficult to catch it. But if you're in an environment that's soaked with the virus,
Sure.
I guess the risks are a little bit higher.
What kind of protective gear do they wear when caring for patients?
So basically, any of us who look after patients with Ebola virus would be covered head to foot in a kind of boiler suit type outfit.
No skin showing at all, right?
No skin showing at all. It's very important that that's the case. And you wear a mask and a visor or goggles.
Okay.
The system that we have for making sure that this sort of equipment is put on properly is to have a kind of buddy who goes through a checklist with you to make sure that you're putting the equipment on properly and more critically taking it off properly, because
Right.
we think that that's probably when
Right.
people get infected.
Yeah, that's what in the U.S., as you know, in Texas, there were a few nurses who got infected after they were caring for a patient. And I think in that case they had some neck skin exposed. That might have contributed to it as well. So how did you were on call, you said, in which hospital was this?
So I was on call at Gartnavel General Hospital, which
Okay.
is the infectious diseases unit for the west of Scotland, basically.
Okay.
And took the call in the middle of the night on a late Sunday night, late December. I'd actually made the mistake of saying to my other half, I think that's the end of the on-call, because it was quite a long one. It was from sort of Friday to Monday.
Yeah.
I said to him, that's it. Go to bed now. That's it. It's all done. And then we had a few days off after that. So I was sort of getting ready to relax. But then that phone call came in through in the early hours of the morning. And
So when you got the call, you immediately went in, and she was brought in as well?
So actually, a sort of machine starts when you get a phone call like that.
Okay.
So I actually made something like 50 phone calls between that moment and then 2 hours later when she arrived. So there's quite a lot of things that have to be put in place. We have very clear protocols, which we're always there. We have had cases of hemorrhagic fever before in our infectious diseases unit, and this is actually the first case I've ever personally diagnosed, although I've been involved in the tail end of cases, and not Ebola virus, but we've seen Congo-Crimean hemorrhagic fever, and we've also seen Lassa fever in the UK.
Right.
So we obviously have protocols for these things as standard, but we had upgraded them fairly substantially because we considered that the risk was very high of getting a case.
So the ambulance that transported her to the hospital had to also be a trained crew that knew what to do in this case,
Yes,
right?
so this is a special operations response team. It's a part of the Scottish Ambulance Service, but there's a very particular sort of protocol for them to follow as well, and they are also fully kitted out in personal protection.
Right, and in the actual truck, is the patient kept in any kind of protective area?
No, so in our isolation facility and also in the ambulance, at the initial stage, it's the protection comes from wearing an outfit yourself. The UK facility, there's only one high-level, high-secure sort of isolation unit in the UK, where happily I trained, actually.
Wow.
And I had a great moment of meeting my old boss, Mike Jacobs, on the Glasgow airport tarmac.
Great.
Something like 26 hours later, that facility is quite different. So there, the patient is inside a tent, and the healthcare workers don't have to wear this sort of equipment which is very hot. You get very rapidly very hot and quite tired, and you can't wear it for very long periods of time, even in the Scottish cold weather. You get kind of hot. I was grateful it was December.
So the patient is also gowned up completely as well, right?
No, she isn't actually yet. So
because you don't actually have a diagnosis yet, right?
No, I mean, of course, there are many diagnoses possible in someone returning with a fever from West Africa. I have to say that epidemiologically and sort of clinically, it was fairly clear that it was likely to be Ebola virus infection. But there are other risks, and I guess malaria would be the highest on that list, and things like typhoid fever. So when we initially see patients like that, we would treat those conditions preemptively.
So when you brought this patient into the hospital, she went into an isolation unit, I suppose?
Yeah, so we have particular sort of allocated rooms, and as an added precaution, we clear some of the beds around those rooms as well, just to be really careful about ensuring that there's no risk of transfer of the virus. So one of my tasks on that Sunday night was to move 6 of our patients to other wards. And unfortunately, you're unable to say to them, "I'm terribly sorry, this is a very rare thing." And, we have to move you, but I think they probably were quite glad to have moved.
Yeah, right. So if this patient had lived in a very rural area of Scotland, would she have been brought to the same hospital, essentially?
Well, yeah, so possibly, yes. There are other infectious diseases units in Scotland, so who have been set up to deal with potential cases. So Aberdeen and Edinburgh also have been sort of set out as centres that would be able to deal with that. Having said that, if you got a positive result in someone in South Uist or something in the Outer Hebrides, you would have to make a sort of case by case decision. But if that patient was stable enough, you would probably move them directly to London from there.
Okay. So when this patient was settled in this area, what did you do next? So,
essentially, it's exactly the same as for any patient. You carry out you take a careful history and examine the patient. We're a bit more limited in our examination, so you can't do auscultation, for example, with the stethoscope because your head's covered.
Yeah.
So you have to use, there's some restrictions on what you can and can't do. We have very clear sort of pathways for making sure that blood tests are sent off to our laboratories. Not quite in the normal way, but we do ensure that those blood tests are carried out. And so we send them in a kind of controlled way to the appropriate laboratories. And then we carry out testing for Ebolavirus. And just before this case, the Edinburgh laboratory, for the Edinburgh Virology Laboratory had actually just set up to be able to do testing for Ebolavirus. Before that, we had to send samples down to Porton Down, which would result in quite a delay. But actually, we had a very rapid
And when did you get the result back?
We got the diagnosis back something like 4 o'clock the next day. So she was admitted around 8 in the morning, and we had a positive result by 4 o'clock.
And then meanwhile, she was kept in the hospital, right?
Yeah, that's right. Mm-hmm.
So, was her temperature increasing during this time?
So the temperature was initially high, but actually fairly rapidly came down, and she was a little bit sort of hemodynamically unstable, but responded very rapidly to intravenous fluids and antibiotics.
Interesting. So when you obtain the diagnosis, what are the next steps in this case?
So then I, actually an hour after I saw the patient, I phoned my old boss, Mike Jacobs, and said, "I think we have a case of Ebolavirus in Glasgow." And he said, well, we can't do that much at the moment in terms of sort of asking the Air Force and so on to organise a transfer until we have a definite diagnosis.
Okay.
But he said, "You've prepared me psychologically for a trip up north."
Nice.
He actually collected another patient from us a couple of years back as well, who had Congo-Crimean hemorrhagic fever. So, he knows his way about.
So once the patient's diagnosed, then she's sent to.
Yeah.
Where?
So there was it was very rapid. It was a very rapid response, and so basically we looked after her for 2 days effectively. And we made a huge effort to try to sort of minimise the number of staff who were in contact with the patient, both from the point of view of those of us who were in direct contact, and then the excellent sister of our ward who acted as a buddy and kind of went through very rigorously the protocol, particularly as I mentioned before, for getting the visor off carefully from the back and that sort of thing. So we really minimised the number of staff that were in contact with the patient, and we tried to minimise also the number of people who would be in contact with blood samples that we'd sent off to the laboratories.
Right.
And then we arranged the transfer. One of the sort of difficulties for us is not so much looking after a patient with viral hemorrhagic fever, but dealing with the sort of waste products and all that sort of thing that build up over time.
Sure.
So the facility in London has an autoclave on site and so on, so it's much easier to to baggage things up and then put it into the autoclave, which is there. So it would be challenging to look after a patient like that for more than a few days, which is why
you sent them off.
That's right.
Her off, yeah. So while she was with you, what sort of care did you provide? You said intravenous fluids. Anything else is done?
Yeah, I mean, I guess so. She was quite stable
Yeah.
at that time. Unfortunately, she became a lot less stable after several days later. But she responded very rapidly to fluid, and as I mentioned, I think it was probably the fluid that had the effect.
Okay.
And I guess the other side of it, it's not just the physical side of this, there's a psychological impact, obviously, when you have to tell someone that they've picked up Ebolavirus,
Yeah.
particularly someone who's seen so many deaths as a result of it. And I think the thing that I noticed that was most challenging, I guess, was that that I'm completely covered up, so she can't see me. And I think quite often when you're giving a difficult diagnosis to someone, you can, you usually sit down next to them, you get eye contact, you have all that sort of non-verbal communication, which was missing. And I couldn't sit down either, so I was just sort of hovering over, trying not to be obtrusive. And then I think that shouldn't be underestimated. The sort of psychological.
Yeah, there's a human
stress,
part of medicine, right?
Of course, probably most of it.
Probably her training, though, helped, right?
Yeah, so I mean, she is a very impressive person, very stoical, very sort of matter of fact, and I think that's right. I think when you've got some medical training, it does help. But the downside is you see all the worst things as well, and you know all the worst things that can happen.
So did you follow her case when she went to London?
She did, yeah.
Did you follow her case there as well?
Yeah, so I went down to visit her there in my old hospital where I started my training, and I was able to visit briefly just to see how she was getting on. And at that time, she was actually starting to recover from what had been a very, very protracted and unpleasant illness. And I mean, Ebola virus infection is really, it is a really nasty infection. And I think on top of that, when you're inside a tent and isolated and so on, it's really quite something to recover from. And a lot of patients are getting complications later as well, and I think we're only becoming sort of increasingly aware now that when we follow these patients up, that there are long-term sequelae or medium to long-term sequelae.
Is that because previously so many had died and the ones who survived just weren't followed up in Africa? Yeah.
I suspect that's the case. I mean, this has been an unprecedented outbreak. I wonder how many cases there have been in Africa which haven't been diagnosed in the past.
Right.
I mean, I guess it's been a bit unusual, and the case definition has been a bit different. There hasn't really, hemorrhage, for example, hasn't been a feature really in these cases, and diarrhea has been a strong sort of presenting feature, and I think that may have been the case before. We may not really know if this has happened in a small isolated village with no medical care, then we wouldn't know.
So aside from intravenous fluids, what else needs to be provided to a patient with Ebola hemorrhagic fever?
Yeah, so there are a number of experimental treatments which we would offer a patient. And there have been 3 Ebola virus cases in the UK, and there have obviously been other ones elsewhere, but they've been offered, treated with a variety of different things, sometimes as the first patient ever to receive it.
Yeah.
So there's the sort of famous ZMapp and ZMAB, which are these monoclonal antibody treatments. And then there's the siRNA treatment, which is quite interesting. And probably the only thing with a kind of modicum of evidence is the convalescent plasma, which has been used in most cases. And I guess that would just be likely to be an antibody-mediated sort of effect.
So are the patients coherent enough to understand when you tell them this is an experimental therapy? Are you okay with it, or?
I think in general they have been, actually. Yeah. I haven't been aware. I mean, I guess there may have been cases. I haven't been involved personally or heard about cases where that discussion hasn't taken place. Like in that case, you would have to make a decision in the best interests of your patient.
Right. Right. So there was, as you know, there were cases that were brought to Emory in Atlanta, right? And one of the physicians there wrote a kind of article or did an interview about what was done to help these individuals survive. And one of the things he said was, besides intravenous fluids, they also had to monitor electrolytes carefully and restore. Is that also part of what was done with this patient as well?
Yeah. And in fact, you also need to make sure that there isn't any other infection. I mean, some of these patients have had bacteremia with bacterial infection. One of the patients that was written up in the New England Journal of Medicine had an E. coli bacteremia. Of course, you might also have malaria. You might have malaria and Ebolavirus.
Exactly,
so all those things need to be taken care of. And I guess when I say supportive care, that means making sure that the electrolytes are stable. Some patients have had to be dialyzed because they've developed renal failure.
Wow.
And
that's challenging, right? With
very. And some patients have had to be ventilated, and that's also a major challenge. And particularly if your patient's in a tent. So there are lots of sort of technicalities to how to look after these patients sort of optimally. So
the tent is not very large, so that's part of the challenge, right?
That's right, yeah. And everything has to go through a port,
So. Wow. I think these are things that most people don't realize, right, when they hear about this, but it's important to know about. How long was this patient in hospital in total?
So I think she was in the London hospital for something like 3 weeks.
So at what point do you decide to release an Ebola patient when there's no more virus detected in the blood?
That's right, yeah. Yeah, so when the viral load has become negative and when the patient is no longer febrile is a pretty good indication of infectiousness.
And then there are follow-ups, I presume.
That's right. So, and the follow-up is done locally. So,
and does that also involve blood sampling and looking for virus again, or is that not done anymore?
So it can do, and many of the patients who have been treated have been nice enough to donate plasma that could be used for other patients, and the blood transfusion service asks for us to repeat testing just to be sort of very, very clear that there's no Ebola virus in there. Yes, I mean, other patients who've had kind of complications, for example, eye complications. I mean, there's a very interesting...
Yes, I was going to ask you about that. There was a case in Emory also, I think, right?
Yeah, so this was the patient who noticed that his vision was becoming very blurred, and he developed a uveitis as a result of Ebolavirus infection.
And they found infectious virus in the... What's the fluid in there called?
Yeah, so it was inside the sort of choroid, but he didn't, interestingly, have virus detectable in his tears, so I guess he wasn't infectious at all. But
it's very interesting.
Very interesting, and I can imagine the ophthalmologist might have been a little bit taken by surprise, because I would have thought that they would consider, after a patient's recovered, your temperature's gone and so on, that this would be more likely to be an immune-related complication, but it seems not in this case.
This happened at the end of my virology course that I teach, and my students all started emailing me, and I pulled a slide from one of the lectures that said the eye is an immunoprivileged site, and I said, see, I do teach you things that are relevant to real life. So in that case, do we think the virus went in there early in his infection and just kind of hung out for a while before it built up to the point where it caused the inflammation?
I guess so. I mean, they
know.
found a couple of mutations, a couple
Yeah.
of non-synonymous mutations in the sequence. I mean, maybe the virus had managed to sort of become more replication sort of competent. I don't know. I mean, we don't know, do we? But I guess it's possible. I would imagine that. I mean, I would imagine that the virus gets everywhere
Right.
when you're first infected.
Sure.
You develop these very high sort of viral loads, and it probably gets into a lot of cells, and I suppose the immune response is, as you say, it's a sort of a site of
These sites like the
sanctuary
eye,
or-
so the testicles too are immunoprivileged, and we know it's in semen for months.
exactly.
Right?
That's another concern, of course.
Yeah, this is difficult. And again, this being the biggest outbreak so far, we're starting to see this because the
Exactly.
numbers are better, right?
Presumably, the risk of transmission is negligible or nil, but people are being advised to take care with sexual contacts
Yeah.
and to use condoms.
This is for men, though, right?
This is for men.
There's no evidence that it's in the female
No.
reproductive tract, right?
No.
Yeah.
I'm not sure how carefully that's been looked at, of course,
Yeah.
but
Well, the first case, then we'll make those recommendations too. So you mentioned that there are other sequelae, right, after you recover. What sorts of things?
Some patients have developed complications like alopecia, so their hair kind of thinning and falling out. There have been, a variety of problems which, perhaps they have an immune sort of basis. It's not completely clear. So I mean, I think there's quite a long list of potential kind of long-term complications. People also, I think the patient who developed the uveitis also developed sort of a lot of joint pain and lower back pain and so on, which probably would be immune mediated. Although I don't know that anyone went into the joints with a needle, but
Right. So basically, these individuals have to be monitored for an indefinite period of time to see if anything else happens to them, right?
I think so. I think you would want to follow someone up for at least a year or so until they completely recovered.
So the other two individuals in the UK, did they recover as well?
Yeah. So I'm biased, but I think that Mike Jacobs provides good care, runs a tight ship, and I think that's incredibly important.
Yeah.
And that's very clear when you look at the survival rate in people who've been transferred to facilities with excellent healthcare.
The problem is, though, in Africa, you have thousands and thousands of cases. Let's say there were thousands and thousands of cases in London, would we be able to handle it in a similarly successful manner?
I think that's so. I think it's true to say that we would be able to handle it in probably a more successful manner, but there was an article in the Lancet, recently saying that if there were many cases, it would be quite difficult for us, for example, to offer ventilation to patients.
Right.
That would be a major challenge. I think however, there are very robust plans for if something like that did happen, although we wouldn't expect that would be the case.
Right.
We always sort of thought that we would get a handful of patients, and that is what happened.
I think the expectation is that we can control this spread
Exactly.
very well, right?
Yeah.
And so we wouldn't get thousands and thousands. But
No.
it really will tax even a good infectious disease unit to have so many cases, right?
I think that's true. I mean, it is taxing. You end up with it requires a lot of input. You need a big unit. You need a lot of colleagues. When you look at the London facility, it's run by people that volunteer to staff it.
Yeah.
And they are pulled in from across London. So you need a lot of staff.
Sure. Yeah, we're very critical of Africa because, you know, we say their healthcare system is not as good as it could be to control this, but it's also, even if it were good, thousands and thousands of cases is very good. Although if it were good, it might not get to that point to begin with, right? If you had an outstanding healthcare system, you could limit the initial
I think that's right. I mean, if you look at the cases, for example, that have occurred in Uganda, where there is definitely a far better infrastructure. I just came back from there this year quite recently, doing some work with them. There's a far better infrastructure there than in West Africa. I've also been to Sierra Leone. I actually was there in the 1990s. And we had very little to offer ill patients at that time. I think things have got a bit better. And now that this Ebola response has happened, there's a huge infrastructure, and I think there's a hope that that will be used to improve healthcare in West Africa. And I mean, there's been a lot of writing and conversation about how many of the deaths that have occurred in West Africa have not been related to Ebola virus, but because their healthcare system has melted down under the strain. So women in labour have died, and children with malaria and so on, all these very treatable conditions. That also has been a major, major problem there.
So will the new facilities that have been constructed, can those be used in normal healthcare going forward?
I think they would probably, I mean, I'm not involved in this, but I would think that they would have to be readapted, but at least, you know, there are buildings, there's organisation, there are people who've really, I mean, I think the local healthcare workers have been incredibly impressive in their response, and you would hope, if there was funding, that they would, you know, I think, you know, they're there.
Unfortunately, once the outbreak is finished, that tends to remove a lot of the support and funding from other countries, right?
That's true. And
we don't realize that it's actually the day-to-day normal infections that kill lots and lots of people that are really important in the long term, right? So I have one more question for you. Just how has this affected you? Have you learned a lot from it, and are you better prepared going forward?
I think when you actually deal with a patient, it gives you a lot more than just reading a protocol or, you know, having a training in the subject. And I think certainly there's a lot to learn from. I guess, how has it affected me? I mean, I've seen viral hemorrhagic fever cases before. It's on a personal level, I don't feel particularly affected. You know, it's part of our job. It's something that we do. But it's never a bad thing amongst your colleagues to have been someone who has diagnosed Ebola virus infection and has that experience, and then, you know, you can use that to try to help. So one of the things I did after this was to report back to the Scottish Government about our facilities and you know, if they could be improved a bit or not, and there are some tweaks that could be made. Definitely.
Did the press bother you a lot?
So it was quite a long shift, as you can imagine, and the patient was quite stable, so at one point I kind of went into the room next door to have a sleep, and was woken up by this sort of flashing and there was a lot of press sort of camped up outside, and satellite dishes. The other thing we noticed actually was that there was some interference with our walkie-talkie system that we used, so those are the sorts of things that I guess that you learn when you actually deal with a real case. Well,
thanks for telling us that. That's great. Gillian, you went to Sierra Leone.
I did, yeah.
Tell us how you came to do that, because you're a PhD student doing basic research, right, on a virus, I presume.
Yes, I work on orthobuenoviruses, so not related to Ebola. But there's another PhD student in Richard Elliott's lab, Steve Welch. He's now finished and works at the CDC, but he used to work for Public Health England. And when Public Health England were tasked with setting up the laboratories in Sierra Leone, they got in touch with him because they knew he had the right experience, and asked him if he would be available to volunteer. And so he went and spoke to Richard, our boss, and Richard gave him his support. And then he knew that I had the clinical diagnostics background, so he asked if I would also want to go or be interested in volunteering. So I said yes.
Right away?
Yeah, right away. And this is all on a Friday evening. So then I sent off my CV.
So is this after the
No, so this
Ebola
is
case
before.
or
So this is
before?
in October last year.
Okay.
So yeah, I sent my CV off on Friday night, and then thought I should probably tell family that this might be happening, and then found out on Monday that I would be going,
Yeah.
and I ended up flying out 2 weeks later.
So did you have to do any training before you went?
Yeah, so there's a lot of training that you have to do. Although Public Health England, they're in charge of running the laboratories and providing training for all the staff. You also, you're volunteering through the charity that runs the treatment centre. So you have to meet that charity's requirements for being an international volunteer. And so I went out with Save the Children. So that involved, they have to do child safeguarding courses, personal security courses, things like that. You have to go have psychological assessments just to make sure you know what you're volunteering for and that you're prepared for what you face. And then also you have 1 week's training at Portondown, which Public Health England labs down near Salisbury, and they take you through everything from a sample reception to unpacking the samples, carrying out the tests, reporting, to make sure that you're then working up to standard and can provide accurate diagnostics.
Do they also
when you're out there.
teach you how to take off the gowns?
Yeah, so the PPE, the personal protection equipment you're wearing in the labs is different from what people would be wearing if they're seeing patients. So if you're on sample receptions, when you're actually receiving the samples, you have to wear quite a lot of protective equipment, but that's more to protect yourself from the high concentrations of chlorine that we would have. So we'd have large buckets of high strength chlorine, which we immediately submerge all the samples in. It's more to protect yourself from getting splashes from that, and then you unpack the samples underneath chlorine, so it's immediately disinfected all around the outside. And then in terms of when you're in the laboratory, we're dealing with the samples inside what are called flexible film isolators, so like big tents. So we put the samples in there, so we can just be in like a light gown and just nitrile gloves. So it makes it a lot easier to work in and to manipulate the samples and things like that. So we don't have to be in the full PPE.
So presumably your lab experience helped with picking this up rather quickly, right?
Yeah, and that was also nice because I'd had 4 years of training in the NHS before, to then be able to use the training that they'd given me when they're needing volunteers. It was nice to put that training to good use, because I was it's difficult for people to go out at short notice, people need to get backfill for their current jobs. So to be in a position where we could volunteer here, and the CVR were supportive of that, and Richard was supportive of us volunteering, it made it a lot easier to be part of it.
So 2 weeks after you were approved, you went down. Was it any challenge getting there?
So that was a big challenge, because when we went out, like all direct flights had been cancelled. And there was also, they didn't know if they would be medevacing anyone if you became sick. So you had to agree that if you became sick, Ebola related or not, if you're in a car accident, you might only be able to receive treatment in country. It was all uncertain. So we flew out via Brussels. So we had to go Edinburgh, Brussels, Dakar, Conakry, then into Lungi, Freetown for Sierra Leone. A lot of other people in the team would go like London, Casablanca, Dakar, Freetown.
How long is the whole trip?
I think it took us about 36 hours.
36 hours.
Yeah.
You could go around the globe in that time.
Yeah.
Right? Wow.
And I think originally like direct flights would have been about 6.5 or something.
Yeah.
So logistically, and that was difficult because then you had lots of volunteers from lots of different areas travelling through various routes. Luggage didn't always come with you. Lab supplies didn't always.
Did you bring lab
come
supplies with you, or
at the start? Some people were taking extra things out because we knew there were supply issues on the ground, and the quickest way to make sure you had it was to
bring it?
hold it in your hand. So that was challenging, and I think it's being questioned now if cancelling direct flights was the right thing to do, because then also proved more challenging when you've got lots of people coming back from West Africa coming in at multiple entry points. If you then want to have screening, that's more challenging, whereas if you had a controlled, just we know that everyone's going to be flying in on a flight, it can make it a bit easier.
That's a good point, yeah. Maybe next time they won't cancel them. Have they been restored yet, do you know? Direct flights?
I don't know if they've restored them I think that there might be some going for the aid workers, but I know a lot of people are still doing, loops.
Right. So when you arrived, where did you go? Did you have a place to live, I presume?
Yeah, so Save the Children meet you at the airport. They take you to overnight accommodation near the airport, and then we were all taken, they'd booked out, the tourism industry has obviously collapsed, so they'd booked out a lot of hotels close to where the Ebola treatment centre was being built, where we all stayed. And that's all in dedicated Save the Children vehicles, and they shuttle you between places, and you're you're never sort of left alone. So we were taken there. The ETC was still under construction when we arrived, and so was the lab. But they had people working on site 24 hours a day with the British Army were out there, the Royal Engineers, and they were overseeing, I think there was 200 local staff helping build the lab. And so we got access to the lab after we'd been there for 3 days, and we opened a day after we got access.
So you just worked every day and then went and slept and went back. You didn't do anything. You couldn't walk around and
no. So
do any of that stuff.
So you were picked up. The way we operated it, we did it in 2 shifts. So if you're in the morning shift, you got picked up at 5:30 in the morning. You were driven straight to the ETC, and then you would get picked up at 2:30.
Tell us what ETC
It's
is.
the Ebola treatment centre.
Okay.
And then you get picked up and brought straight back to the hotel compound.
So the ETC is where patients are kept, right?
Yeah.
And what did you do there? Tell us about your work.
So I was working in the lab. So we would receive samples for testing, and we would test for Ebola virus disease, and we would also test for malaria. And we would receive samples from the Ebola treatment centre, and we would also receive community samples.
Mm-hmm. And you screen these by?
So for the Ebola virus disease, it was a real-time PCR assay. And then for diagnosing malaria, it was a lateral flow antigen assay.
And the PCR you've done here, I presume, so you know how to do that, right?
Yeah.
And they provide primers, reagents. It's all standardized, I presume.
Yes, yeah, it's all standardised. So before we opened, we got control samples sent from another lab that had already been set up in country, and we blind tested them, so we didn't know what the results were. And then we sent those results out to confirm that we were testing samples appropriately and getting the right results.
So in addition to you in this lab, who else, how many other individuals were working?
So in the team that I went out with, there was 12 of us working in the lab, and we were a mix of university students. Here there was scientists working in the NHS, there was scientists from Public Health England, and there was scientists from DSTL, which is next to Portendown in Salisbury. So we were quite a mix.
And how many samples would you process in a day?
I think at the highest amount we managed to process about 140 in one day, but at the start we were receiving about 300 samples a day. There was a massive backlog when we opened in October, and trying to keep up with that was really challenging, because the first day that we managed to cross 100, we thought we're doing something here, we're really contributing, but then an ambulance would arrive with another 200 samples. And
how many PCR machines did you have?
So I think we had a bank of 5.
Mm-hmm. And how many samples could each machine do?
Each sample, it could do 16.
16. Okay.
Controls.
So were they all going at once, and then you'd have downtime? I mean, how many hours is this? 4 hours, 6 hours?
Yeah, well, it would all depend. At the start, we had also challenging problems. It was the rainy season when we were trying to open the lab, and there was problems with electricity supply and things like that. So at the start, we couldn't run all of them at once, because then it would cut out and things like that. But once the lab had been up and running for a little while, and we dealt with sort of the electricity problems, we could have all 5 going at one time.
So sometimes you said you arrived at 5 a.m., right?
Yeah, we'd open the lab for 6,
and
so
then
we'd get bussed in.
You would work till when?
We would work until about 2 or 3 in the afternoon, and then we'd cross over with the next shift, and they would work through until about 10 or 11 o'clock at night.
So during that time, did you get breaks where you could just sit down, or were you on your feet constantly?
When we first opened, you just took them sort of as and when, especially in the early days when we were receiving a lot of samples. You would spend a lot of time outside at the sample reception, and that's when you're in the more full PPE, you've got the visors on, that can be very hot and sweaty. So we would have to just make sure, and although you might feel pressured to come back into the lab and do more samples, you'd have to say, no, go, sit down, have a drink of water.
Yeah.
You're more hazardous if you're not.
Yes, of course. And then when you left at 2 p.m., what did you do the rest of the day? Just relaxed?
Make sure that results are getting reported okay. You're maybe visiting warehouses to get more equipment to restock the lab. You're checking in with the other shift to see if there's anything that they need, if they need something put on a shuttle bus to go up. Make sure that they get dinner and things like that. So although you're away from the treatment centre, your mind's still very much there and making sure everything's...
But most of the time you were very close to the treatment centre, or did you...
No, so we were about half an hour away.
Half hour?
Yeah.
So, I mean, did you get any sense of what life was like at all, or was it just so much in the lab that you couldn't do that?
A little bit. So in the early days, there was a lot of waiting around as well, sort of for deliveries of buses and things like that. So you would get chatting with a lot of the local staff. They would wait with you and help you sort of carry things in, and so you would chat with them. quite a bit. They were all amazed that you're not married off yet. And things like that.
Of course.
With 5 children.
Did people want to marry you?
I had a few proposals. That was quite nice.
Not surprising, yeah.
But when I told them how cold Scotland was, they weren't so cute.
How long were you there in total?
I think in total it was just over 5 weeks, 5 to 6 weeks.
Were you
the
exhausted
travel.
at the end, or you're okay?
I wouldn't say exhausted, no. I think it was nice to see that we were leaving behind what was a functioning lab. When we first arrived and saw it was a building site, we just thought, we're going to contribute nothing here. How can we get this up and running? It seemed so far off that this would be a functional lab providing diagnostic support. And so then when it came time for us to leave and the next team came out, when we were getting to show them around the lab and sort of saying, and this is turnover and this is how you report, it was really nice to be able to see that this lab is doing something, it is offering support, it is important. And yeah, no, it was good to come back. And
So in talking with some of the people living in the country, did you get any sense of how, were they frustrated, or was it just life as normal, or did you get any of that sort of information?
I think they were incredibly frustrated, but then they were also, they were really happy is maybe the wrong word, that they could see that this treatment centre was being built and finally something was being done, that people did care, that they weren't just being abandoned and sort of left to deal with this by themselves. And also then, as a more practical standpoint, because the ETC was being built there, that meant that they could get jobs, because a lot of them have lost all their jobs, because all the schools got closed, so there was no jobs for the teachers, a lot of the industries have gone down. So in a practical standpoint, that's probably more why they were happy an ETC was being built, because it gave them a means of feeding their families again.
So while you were there, and when you returned, did you have to monitor your temperature?
Yep. Yeah, so you have to monitor your temperature twice a day, and then also every time you leave the hotel, you get temperature checked. When you arrive at the ETC, you get temperature checked. When you leave the ETC, you get temperature checked, and then when you go back into the hotel compound, you would get temperature checked. So there's a lot of temperature checking, and you always get slightly nervous, even though you know that you're fine. It's sort of an intake of breath before you hear the beep.
And then when you came back to the UK, you had to have temperature checks for 3 weeks, right?
Yeah, so you get a pack that that tells you all about the screening, and before you can leave Sierra Leone as well, you have to get cleared for travel. And with that, you're given a categorisation, and you're told what will be expected of you when you get back in the UK, and then that's all met and followed up. But because we'd not been dealing with patients, we didn't have any travel restrictions, because I had no direct exposure, so I was able to get a hug at the airport when I landed.
So were you relieved after the 21 days were up, after you returned?
I was really, part of me, I think I wasn't worried about Ebola. I was more worried that I might end up with flu or something else minor would happen. And that because people invest so much in your training, and that it's really important that they're trying to get all of these support services up and running, that if you then can't contribute to that after they've put in so much training into you, that would just be really frustrating. So I think you come back, and then you also feel a little bit guilty that you've come back, because you know there's still so much work to be done, and your brain's sort of like, well, how can I get out again? But then you do have obligations here as well.
Yeah, of course. So any time while you were there, were you worried that you would get infected, or did you just work as you normally would work?
No, we just worked. I think you form a really close bond really quickly with everyone else that's in your team, and you know that you're all working safely and looking out for one another. So it was more the issue of, there was some nasty colds going around, so it was just really keeping clear of anyone that looked like they had a cough. And then I've never used so much chlorine hand wash in my life. And there's no physical contact at all.
It must have done things to your skin, right?
Yeah, so your skin, it can dry out, and then your shoes get bleached as well, because they chlorine wash your shoes every time you get in and out of any vehicle or coming in and out of the ETC. And your trousers get bleached because you're going like this to dry your hands. So
Right.
I have all my summer clothes are chlorine stained.
Could be a fashion statement, you know. Yeah. How was the food there?
The food, I mean, it was good. We would get breakfast before we left if you're on the morning shift.
Was it locally raised food, or was it all brought in?
Well, there was a mix. So there was some stuff brought in, and then there was local food as well, and there was lots of plantain, so that was really nice. Obviously, when you're working on site, the food would be more variable, but we would get food. So, and no one got sick from the food. Like the hygiene was really good,
Right.
and that was important because there were some places that I think were running at such a high loss of staff just through diarrhea illnesses from food hygiene that they would have to temporarily shut down because they couldn't safely staff those facilities. So that was a really big aspect of the logistics for Save the Children, just making sure that we were all getting appropriate accommodation.
Wondering if, because when you go to a new place for an extended period, often you get, from the food chain, you get GI illness and whatever, but you were okay, right?
Yep, no, everyone in our team was okay. I think there was a couple of people that reacted badly to the anti-malarials, and that's a condition that, as a volunteer, you have to take them. And if you have an adverse reaction, that's not your fault, but you will get sent home.
What did they give you? What, do you remember?
So I took Malarone, but it was a choice. So if you'd taken a different one and that had worked well for you in the past, you could have had that one. I hadn't taken any before, so I opted for Malarone.
So what in the end, what do you learn from this experience? Is it something you took back, or are you going to forget it in a few months?
No, I think it seems quite abstract and surreal almost, because it's so far removed from anything you've ever done. It's almost like that was someone else that went out and did that. I think I've learned more patience. And team, it's so important to be able to work with the people that you're out with. They are your support network. You don't really have communication back home. You can't see anyone else. You're in really challenging circumstances, especially before the ETC opened and people would come trying to get in for treatment, and you would see people pass away outside, and you would be faced with that like every day. I mean, it's nothing to what all the clinicians would face with once the ETC opened and dealing with patients, but that is challenging. And then you just want to shout at people, we need to do more. Like, this shouldn't have been left to get to this stage. So I think, and I would definitely step up again if it was ever needed. I think we have to take responsibility.
Yeah,
we live in an international world.
That was going to be my last question. Would you do it again? Yeah.
I would encourage anyone else that, I mean, they still need volunteers. It's still going on. And I just think we all have responsibilities.
So if someone wanted to volunteer, what would they do?
If you're wanting to volunteer for the labs, you go through Public Health England. They've got a training scheme set up where you can apply, and then they bring people in for training and we'll fit you in on a rota. Also, there's WHO, and all of the major charities are still looking for people to do like contact tracing, epi work, logistics support. They're needing volunteers in every single area.
All right. Well, thanks for sharing that with us. Adam, have you been to Sierra Leone?
I haven't, no. Some of my group are currently out there working on some of the sort of more epidemiological follow-up. Obviously there's a lot of different data sources, different areas, different authorities, and I think one of the things that's quite important at the end of this outbreak is to be able to work out what actually happened. And so really trying to make sure we know what data's out there and we know what's linked, and I mean even things like contacts of cases compared to the more clinical symptomatic data, being able to link those kind of different sources of things.
So that's one thing that I've always wondered, what kind of data are we going to have from this? Because a number of people I know who have gone said, you can't just take serum and bring it back and study it in your lab. They want you to take care of people.
And I think throughout we've been very aware of it's the balance between treatment and the sort of the science that you need. And I think the two things are very intertwined. You can't treat and control disease effectively unless you understand it, but you can't understand it unless you're getting the data from the patients.
Sure.
And I mean the initial, so the viral hemorrhagic fever forms they're using initially, I mean if you see them, they're pages and pages and very detailed, and especially if someone comes in late with very severe symptoms, you're unlikely to be able to get all that information from them, which early on made our job quite difficult because, I mean, from a modelling or forecast point of view, you've got a wish list of what you want, but you have to be aware of that's not the situation you're dealing with and try and get around that. So I think that's something that that coming out of this is being aware of what data you have available, what data you could have available, and then things actually in real time you're never going to have, and working out ways of dealing with that.
So one of the things you published on early in the outbreak was the case fatality rate, right? Can you tell us a little bit about that?
Yeah, so whenever you're working in real time, delays in data and just in the process of infection is really important, and they can sometimes throw up some results that at first glance look quite odd but actually have a fairly logical explanation. So one was the case fatality rate, so this is the number of deaths divided by the number of cases, was seemingly very low. So it's 50%, in other outbreaks it had been 70, 90, and there's a lot of media speculation of, is it mutated virus, is it something different, is it clinical settings, what's going on? And actually what was happening is that it was just a simple matter of the calculation they were doing. So what was happening is people were taking the number of reported deaths, which was back in September, maybe around 1,000, and divided by the number of reported cases, which was 2,000, so you got a 50% value. But the problem, of course, is when someone's reported as a case, it takes time to know what happens to them. So for example, when there was those early cases in Nigeria, about 10 cases had been reported and there'd been 1 death. So if you did it naively, you say, well, it's a 10% case fatality ratio. Obviously, the other 9 cases are still in hospital, and we don't know what's happened to them. And so the piece we published adjusted for that, because the risk, of course, is, say, within Nigeria, you start off with 10%, then you start getting the other outcomes being reported, and suddenly your case fatality ratio is climbing, and everyone starts panicking. So what we wanted to do is adjust for that and say this is probably going to be, we reckoned around 70%, and subsequent data which actually has the individual, for each patient, their known outcome was around that 70% value. So it looked like this wasn't a particularly different virus. It was purely an issue of how you analyze the data accordingly.
So you devised a calculation to accommodate, or you just waited until all the...
So we devised, it was an existing model used in the 2009 pandemic. But essentially, if you know the distribution, so you know on average how long it takes to find out the outcome, you can shift your curves in your data. So you can estimate how many cases you think you know the outcome for already.
So in the end, it was about 70%?
So we said around 70. We didn't want to be, it's the kind of, we want to be about right. And we said around 70%, and subsequent, I think the New England paper that came out said 69. So we were...
And as of today, we're around there as well?
Based on what we've got, we're around there, yeah. There's some variation, partly by chance, maybe some other causes. One of the issues as well with case fatality rate, it depends on when people come in. So if people are coming into hospitals later, you might be missing those very severely ill people that die early on. So you might get some variation just in terms of who's coming in and when they're coming in.
So that in itself also can influence the CFR when you come in the illness, right? If you come early on, you have a better chance of surviving.
You do, but you can get some sort of slightly counterintuitive things. So in some areas in the centre, there's actually people who were coming in later were more likely to survive on the face of it. But the reason was the severely ill people weren't being seen in the data. So you just, if someone's had Ebola for 7-10 days, they're more likely to survive because they haven't got that initial very high viral load. And then as well, you had things, for instance, in some data of people with certain treatments might have had a higher fatality rate, but again, it was just because they were more ill, so they were more likely to get those kind of treatments. So there's a lot of things you have to be careful of that at first glance look strange, but actually it's just the way things are reported.
Okay. So you've also done some modeling of transmission, is that right?
Exactly, yes. So throughout, initially we were working with MSF on their outbreak data in Montserrado County in Liberia. This was probably August last year. And that was when the outbreak was really kind of starting to take off in that area, trying to give them some short-term forecasts of what kind of bed capacities they're looking at. And actually, the epidemic was growing very fast at that point. It was doubling about every 2 weeks at one time around Monrovia, which meant that obviously if you're trying to get beds in place, or your beds are coming in a month, suddenly you're having to adjust what you do based on that really fast growth. So that's what we're doing. And then later with Save the Children and UK government in Sierra Leone, some of the additional beds going in, estimates partly in how many cases would be expected, but also different intervention strategies and what are the key factors. Is it getting the bed capacity in, or actually one thing we found was in a lot of locations people were taking a long time to come in. So even if you stuck as many beds as you could build, you wouldn't control the outbreak because people were taking just too long to come into treatment.
And in the meanwhile, they're infecting other people?
Exactly, yeah. So in some areas, it was taking people almost a week to come in for isolation. So although a lot of treatment centres had fantastic infection control measures, if people were in the community for too long, that was So it's really identifying those features of transmission and behaviour which were crucial for control, and thinking about how that could be tackled.
And the data you worked with came from MSF, you said, is that right?
So initially it was with MSF, and one of the challenges there was we had data within the treatment centre. So initially when the treatment centre wasn't full, you could get some measure of how much infection because you knew who was turning up. But in late August, I think it was the L2 and L3 started to fill up, and because they saw people arriving in ambulances, didn't have a measure of what infection was outside. So essentially your model flatlines because it's just the capacity of the centre. And that was quite challenging because you essentially had to go back and say, look, we can't forecast because all our data depends on who's in the centre. And as soon as your centre's full, we've got no measure of what's going on further afield. Since then, we've worked with WHO, so we've had access to the more extensive line list data.
But all we have are case counts and fatalities, right? We don't have any other data in addition to that, like serology, for example.
So there's not serology. I mean, you have data from the case report, so the hemorrhagic fever. So yes, it's basic clinical data. In terms of serology, I'm not aware. I mean, that would be one thing that I think would be very interesting, is to actually follow up with paired serology. And our group's working on a serious survey in Democratic Republic of Congo, actually, because they had a parallel outbreak, and actually doing a follow-up afterwards, because I think it'd be really interesting to see whether there's potential for asymptomatic cases. You know, if you actually do a population sero survey, what shows up?
So that's not been done yet anywhere, right?
Yeah, but there's one in progress in DRC at the moment.
DRC, okay.
But that's something even in West Africa, just to get an estimate of what there is. And then even in real time, people who are testing positive or negative, is that a true result? How does that actually reflect what's showing up in sera?
I think in the West Africa, especially where there's been so many symptomatic infections, it would be really interesting to know, right, in the general population, how many people have actually been infected and are fine.
Absolutely. And we always work, certainly from a sort of epidemiological infection control point of view, on the assumption that most people are symptomatic and they're only infectious when they're symptomatic. That's the kind of the rule you base all your contact tracing. Right. And even things like the incubation period, you kind of go for the 21 days. That's actually from the 76 outbreak, the original data, that period. And maybe that's not quite accurate. So all these things we have and assume might need tweaking, and that could have a big effect.
Well, you work with what you have, right?
Exactly, yeah, and we work on the best of knowledge. I suppose that's just science. But you mentioned earlier as well with the kind of sexual transmission, and there was an example, I think, a couple of months ago of a infection chain reintroduced to a country with no obvious contact, and it may well have been. So these kind of things, which we didn't think about before, are now cropping up and might actually have an effect on the dynamics.
So before this outbreak, had you worked on Ebola?
So I'd worked on other emerging infections. Actually, we started to look at the original 76 outbreak because the epidemiological investigation notes, so Peter Piot, who's head of London School of Hygiene, his original field notes were in the archives.
Wow.
So around, I think it was just after Easter last year, because Ebola we were aware of it, but it hadn't reached the scale that's obviously since become. But we looked in the archives and actually tried to sort of go back, and we've since done a lot of other past outbreaks, just to go back and reanalyze the data with the kind of new techniques and see if, I suppose, the anecdotal story of what happened lines up with what actually went on.
And what did you find?
So in 76, we actually found that change of behaviour was incredibly important. So you had, the outbreak was centred on a mission hospital, so it was Yambuku in DRC, and it was actually contaminated syringes that were infecting a lot of people. So a case came in, I think, with malarial symptoms, and then there were 5 syringes that were getting reused every day. So that created a lot of cases, but then the hospital closed and the epidemic waned. But using these models, we really found evidence that the community transmission rate dropped a lot before that. And talking to some of the people who did the investigations, some of the CDC guys, it really seems that people didn't know what the virus was, they didn't really know the biology, but they knew something was wrong. So they were almost in the population practicing effective infection control without really knowing what they were dealing with. And that's what turned the outbreak over.
Really?
And actually looking at the current outbreak, in a lot of areas there's evidence that's happened. Again, that's something we just don't understand. No one can predict when Ebola peaks because we really don't understand how people react to it and how attitudes change over the course of an outbreak.
So I was going to ask you, in the current outbreak is pretty much over or not quite? What are the cases now? Do you know?
So last week there were 16 in Guinea and 15 in Sierra Leone. So that's actually, it's increased over the past 2 weeks, which is troubling, of course. And I think one of the characteristics of Ebola is that transmission's not very even. So a lot of people don't affect anybody, and you get a few of these, you could call them super spreading events, but situations where a lot of people are exposed to a virus at once. And this kind of has 2 features. The first is that it, in theory, makes the transmission chain much more fragile, because a lot of people aren't causing infections, and if you can target those events, such as funerals, then you're much more likely to control the infection. But the other problem you have is, in that final tail of the outbreak, there's a lot of randomness and random effects. So all it takes is one funeral or one context, and suddenly you get this flare up in cases again.
I see. So we don't understand why the outbreak has declined, right? We don't know the factors involved.
I think we know the sort of candidate list of factors. Okay. There's, in a lot of areas, I think the international response, so adding additional beds combined with local measures, so community interventions and engagement, as well as behaviour turning outbreak. The contribution of those individual ones is something that's quite difficult to pick apart. Especially a lot of the control measures were designed as a package. You know, you put a new ETC in and you combine that with better local measures as well. So it's very difficult to tease apart. But I think for the next outbreak, it's really something we need to understand.
So will you be looking at the data from this outbreak for a while?
So that is something, yeah, we're continuing to look at what's happened during this outbreak, and then more recently look at the implications, of course, for the vaccine trials, because some of these are starting to start up. And obviously when you've got a decline in the number of cases, then that can have implications for how successful trials
So can you tell us what vaccine trials are starting?
So underway, there's been some in health. So in Guinea, there's a trial in healthcare workers. So that's obviously a high-risk group that they've been looking at.
Is it phase 1 trial?
So that's entering phase 3.
3?
So it's actually, yeah. So there's been a number of phase 1 trials that sort of demonstrate safety. There's also a ring vaccine trial underway in Guinea. So this is a slightly unorthodox trial design, rather than the standard randomized control trial where you divide people into 2 arms and give this large population a vaccine, don't give these guys the vaccine and see how the 2 compare. This trial is actually using, it's almost like the smallpox eradication approach. Right. So if you get a case, you create a ring, and then in one ring you vaccinate people immediately, and then in another ring you vaccinate them after 21 days. And hopefully if you've got this very rapidly changing epidemic situation, this will give you a better chance of working out whether the vaccine's effective or not.
So there's a regular controlled trial underway, you say, then there's ring.
So there's a regular trial in healthcare workers. There's others that are in the process of starting up. So a few months ago there was a trial in Liberia, for instance. Obviously they have no cases now, so it would be pretty much impossible to demonstrate efficacy. And I think even now, some of the big trials starting up, the forecasting we're trying to do is estimate how many cases they're likely to see. Because often for these trials, if you're seeing dozens of cases, that might be enough to demonstrate that the vaccine works. If you're seeing 5-10 cases over the next few months, it's going to be much more challenging depending on how effective the vaccine is.
Yeah, so that's what you're working on, trying to figure out what the numbers.
So in our group we're working on a number of different areas, and I mean throughout the epidemic we've been trying to put together real-time forecasts, because different groups I think have very different interests in what they want to look at. People who are on the ground working in ETCs and these kind of things just want a measure of how many cases and how much transmission is in a particular area. But then, of course, pharma companies and those who are actually wanting to conduct these trials need an estimate of, in the next 3 months, what we're expecting to see.
So from what you know so far, will we be able to get reliable data from these trials?
It's very difficult to say. I think we're going. I mean, we're hopeful, but I think on that border between, it could go either way, and it's very difficult to say definitively that there won't be enough cases or that there will. But I think really the sooner these trials get started up, I think a trial aiming to start in the autumn will struggle to, based on current patterns, to reach a definitive outcome.
So the 2 you mentioned are already in progress, right?
So those are in progress, yeah.
Do you know what vaccines they are offhand?
So it's the VSV
vector. Okay.
Yeah.
Both of them, yeah.
To my knowledge, yeah,
Okay.
I think so.
There's an adenoviral vaccine as well, isn't there? It's an AD3 vaccine.
Yeah. So there was one that was a prime, one that was a prime boost, and one that was a single dose, I think.
I think the prime boost was an adeno MVA,
Yeah,
right?
that's right.
Combination.
Yeah.
And
Yeah.
so that's also being trialed in one of them, or
There's plans for trials,
Plans,
but
yeah.
I don't think it's yet in the field.
so you mentioned the next outbreak, right?
Yeah.
So, well, in that case, wherever it be in Africa, I mean, we sort of know where it would be based on the vector, right? The bats that harbor virus, but we never can know for sure, right?
Exactly, yeah. And there's been some work by some guys in Oxford who've done a lot of the mapping for other
Yeah.
infections, where you try and you pick out conditions that
Right.
match Ebola, and I think essentially you've got that broad region across Central Africa where there's potential for that to
Right.
happen.
So, if there is an outbreak, will it be possible to go in and do a vaccine trial, or is that impossible in an outbreak situation?
I think it'd be challenging. I think one of the things this situations really help people understand is doing these vaccine trials on much shorter timescales.
Yeah.
Because it's never been done before. It's always been a much longer term program. And you've got a slightly odd situation where you were in the early stage of the outbreak, we really wanted the trials to be done quickly because we saw the case counts growing so high. No one,
Yeah.
I think at one point, could really envisage controlling the outbreak without a vaccine. When we were looking back to
Right.
August, September, the cases were growing so rapidly, you thought we have to have some kind of external, additional thing to help us. But then in the later stages, you're in a hurry to do the trial because the cases are waning so
Declining,
quickly
yeah.
that you've really got to get in there. And it might be possible that if you have outbreaks, it's a trial where you design it so you can test it on a certain outbreak and then pause it and then start again. But then you go into the issues of is that a fair trial, and actually is it consistent? And there's been a lot of debate, I think, particularly in the drug treatments of the ethics of can you do a randomized control trial on these situations? Can you give a placebo? And in some areas, it might not be that communities are very receptive to you. You know, you've got a severe disease, and actually giving placebo drugs when you have one that potentially works, it's quite hard to communicate the scientific rationale for doing that when you potentially have a treatment that could help people.
Right. I remember early on in the outbreak, or maybe a few months in, the CDC made predictions of millions of cases.
Yes.
That was based on no intervention, right?
It was based on no intervention. I mean, yeah, so that number, actually the model, if you keep running it, will just keep going up. I think you'll hit the billions eventually. I mean, in the early stages, the cases were going up.
Yeah.
So if you took that pattern and kept going, you would just keep going indefinitely. I think one of the problems with that estimate is there was a lot of uncertainty at the time. It's like that John Maynard Keynes quote, isn't it? If it's better to be approximately right than precisely wrong. and I think really it could have been even higher, it could have been even lower based on what we know at the time. We've subsequently gone back and retested our forecasts. And actually you almost just get it could go high, it could go low, we really don't know. And I don't think anyone could have predicted when the disease would peak. And I think publishing single numbers with actually no kind of estimate of the uncertainty involved isn't that useful. I think what was much more useful was estimating how quickly it was doubling and how quickly we needed to get the interventions in place.
So that's not something you would have done as an epidemiologist, right?
No, and I think even in those conditions, trying to forecast 4 or 5 months out is near impossible.
Yeah.
You can come up with something reliable maybe over a month window, but there was so much uncertainty in that I think going much further forward, it's very difficult to actually say anything reliable.
So all it did was scare people, really.
Yes, I mean I've seen people make the argument that publishing a big number scared people into responding, and then that response controlled it. But then on the other hand, it might be that there's other features like behavior. It might be there's some innate things that narrative doesn't really capture, the kind of just the response taking credit. So I think we need to think more about how models work, and when we come up with those early forecasts, actually think, are they useful and do they actually represent what we know about the disease?
Okay. So one thing I had wanted to ask you was, do we understand in any way why this outbreak was so large?
So that's one of the things we've looked at going back to previous outbreaks as well. And in a lot of places, there's evidence that in the early stages at least, it was something that had the potential to grow. So we measure it in this reproduction number. For each case, how many more cases does it generate? And even the original 76 one, initially that was quite high. So each case was generating quite a lot more.
What is quite high? What's that?
So this was around 2 or 3. So for each initial case, you were getting 2 or 3 more, and it was growing. But of course, early on, you've got a lot of randomness. I think, as you mentioned, there's a chance that there's been a lot of single cases or in isolated villages that we just never hear about. And often it's a chance event. I think in Sierra Leone, there's a funeral, someone came across the border. If that hadn't happened, and the problem is we only see the world as it is. We don't know if you rewind history whether you'd see the same pattern. And partly, I think, just the setup in these countries, so the mistrust of authorities and just the way things were set up was really kind of conducive to transmission. But I think there's also just an element of chance in that over time, Ebola had always had the potential to cause a larger outbreak, but behaviour and control measures had got in time. And actually, we've done it, if you rerun those simulations from earlier outbreaks again and again and again, actually you can sometimes see a much larger one. But of course you don't, because the general behaviour is much smaller. So I think we can expect more outbreaks of Ebola, and occasionally they might be large. So we need to,
assuming no intervention, right? But if we have a vaccine, there shouldn't be any more. Right?
So I think that's one of the real motivations for having a vaccine and a drug treatment or otherwise.
Right.
That we don't have to have a situation where just getting isolation and contact tracing is the only thing we can really do.
Right. So you mentioned some vaccines, but are any of the monoclonal therapies in trials? Do you know?
So I don't know the details of those. I know a few in trials. I think again the issues is with lack of patience.
Yeah.
I know in some situations, in some areas, I think there's conflicts between multiple trials where you've got very few patients. So I think when you've with any situations where you've got a lot of different organisations trying to conduct competing studies in the same area, it doesn't always work in the most cooperative way.
I guess for these monoclonals, if you can do a phase 1 and show they're safe, then in an outbreak situation you could give them under compassionate use guidelines, right?
I mean, I think one of the things that we have to address is setting up the infrastructure.
Yeah.
And I think, organisations like the World Health Organization need to create an infrastructure for these sort of trials. And we've moved into a sort of a new era of being able to develop treatments quickly, and but we are very slow at rolling them out. I think actually this was quite fast, but it wasn't fast enough for a lot of people.
Absolutely, yeah.
And we need to address those ethics now and set up the infrastructure now, and probably work on trust and education locally, and trying to sort of develop these things so that, because my feeling is if I got Ebolavirus, please give me a monoclonal antibody, right?
Yeah.
You probably take it, particularly if you were deteriorating or had a very high viral load.
Yeah.
And that's because I have I've been lucky enough to learn a bit about how these things work, and so those things need to be put in place.
Yeah.
The other issue, though, was manufacturing of those, of monoclonal antibodies. That was taking a long time, and it wasn't possible to produce enough, I think, to get it rolled out quickly.
Yeah, I think you're saying just in terms of the timescales, that a lot of these things weren't even in phase 1.
Yeah, sure.
And it's not that you had a bank of things that you knew were safe and that you could take to the field, that you actually almost had to start from scratch.
Yeah, that's right. So exactly. As you say, if you have a bank of things you can test, then.
Well, many of these vaccines and therapeutics have been around for a while.
Yeah.
It just never got into humans at all, right? The outbreaks were relatively small, and that wasn't. And this is really, in a way, this outbreak catalyzed it. Everything went forward.
Yeah.
So if there's a good part.
I think you also have to be careful. So, there were some studies testing lots of sort of, lots of well-known medicines against Ebolavirus,
right.
and there was a huge list of possibilities.
Yeah.
But some of them, although they may be on our formulary for prescription and license for use and so on, they may not be terribly safe to use in people who are hemodynamically unstable.
Right.
So, we need committees to be able to look at these. International committees to look at these sort of treatments.
I think one of them was verapamil, right?
Amiodarone was one of them that I was very. I think amiodarone. I don't know the ins and outs of this, but amiodarone is a medicine that we use as clinicians for people who have cardiac arrhythmias.
Right.
And it is a drug which is not without risk.
Yeah, right.
And I think if you've got someone whose blood pressure is low, who's losing lots of fluid, who's unstable, perhaps you might want to think twice about using that particular drug.
And there's also with a lot of those potential treatments the issue that if you try a lot of things, one of them might work by chance. And so there's always, going back to the ethical issues, that if you've got that kind of study population, you might say that actually it's unethical just to kind of throw anything at it when you've actually got an opportunity to test something which there's a decent biological reason for it working and actually establish efficacy, so you have a treatment that works.
I think what's critically important though is to, to maintain trust and to build up trust.
Absolutely.
You need to not have any trial which is with an unsafe agent.
Yeah.
Or an agent that you could have predicted might be unsafe, and you need regulation and monitoring in these sort of. And my understanding in these situations is that case notes and things for individual patients are scant. So going back and looking at the records and so on in order to learn things in retrospect is quite challenging. So that sort of infrastructure using sort of clever computing and kind of mobile devices and so on in the field could be really improved.
And WHO needs to coordinate this, right?
I think that's right. But of course, they're resource limited.
Yeah.
So the UN needs to put more money into WHO. I mean,
Well, certain countries need to pay their UN and WHO bills.
That's true.
And they don't. And I think we're guilty of that. I meant to go back to one issue with this current outbreak, Adam. A number of people have said that it was so large because it wasn't detected for a long time, wasn't diagnosed, right? Is that not true according to your thoughts?
I think in a lot of what's interesting going back historically is a lot of the things that are attributed for reasons this outbreak of being a problem have happened before.
I see.
So I think the 2000 Uganda outbreak was originally, I think it was dysentery, and another one's been attributed to typhoid. A lot of these febrile diseases. And then again, resistance has appeared in past outbreaks, that there's been a lot of community resistance to healthcare measures and these kind of things. I think it was just the combination of a lot of these factors all coming together. So you didn't have the capacity in terms of beds, you had the mistrust, potentially didn't have the diagnostics in place, and as well, you potentially had some bad luck.
As you said, it could have happened before, right?
Yeah, and also just again understanding where the reservoir is. I know there's been some studies in the past with serology getting some measurement of some reaction to Ebolavirus, but why that wasn't there before, or why it wasn't detected before, I think is quite an interesting question.
Yeah, that's a really important area, because if we knew for sure the reservoir, we could try and stop the spillovers, right?
Yeah.
And that's what initiate every outbreak, a spillover of some sort, right?
Exactly, yeah.
So going forward, you're going to be working on the vaccine trials, is that right?
So there's a couple of trials that people are either working in advisory capacity through WHO or with some of the trials themselves. But again, this is kind of a rapidly changing environment, and it's one of these things that you come up with a model and you come up with a forecast, and then a month later you're dealing with a completely different situation.
All right, great. Well, thanks for that, Adam. And this episode of TWiV will be with all the others at iTunes and at twiv.tv. And if you have a question or comment about this or any other episode, just send them to TWiV at twiv.tv. And I want to thank all of my guests today for participating. Emma Thompson, thank you so much.
Pleasure.
Gillian Slack, thank you.
Thanks.
Adam Kucharski, thank you very much.
Thank you.
And again, Adam is at the London School of Tropical Medicine and Hygiene. Emma and Gillian are here at the Center for Virus Research, CVR. This episode could be back in the CVR. You get that? I want to thank the British Society for Cell and Gene Therapy, the Society for General Microbiology, the MRC-CVR, all of them for supporting my trip here. I've been here for almost a week, and all of those organizations participated. And I want to thank Connor Bamford, who's been sitting here watching, for organizing this and the other TWiV. Thank you, Connor. Did you like it?
Yeah, it was great. Great. Learned a lot.
Great. I hope our listeners like it too. I'm Vincent Racaniello. You can find me at virology.ws. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.